Good afternoon.
I think there seems to be some technical problems, and I think our chair is not here at the moment. Is that correct? And I can probably introduce on behalf of Sophie or Jane, if she's able to speak, to introduce everyone to this webinar for the Volunteering in International Psychiatry Special Interest Group. Sophie, the chair, I'm sure will get back at some stage, but I'm suggesting that we fire ahead with Mohammed, if that will be okay, who's going to do his talk and introduce to us about international strategy, I believe.
Okay.
Okay, Mohammed.
All right. Thank you, Peter, for taking a lead on this and dealing with this technical problem. Apologies for everyone. I don't think you can see me because I don't have the right to switch the video on. So I'm afraid you're going to settle for just my voice. So again, thank you for everyone for joining in today. It's a pleasure to talk with you, to share with you a really exciting development in the college, and that's the launch of our first international strategy. And just to explain a little bit of background for colleagues who are not aware of it, that the college, almost 1/5 of its membership are based outside the United Kingdom. And just below half of its UK-based members have obtained their primary medical qualification from outside the UK. So the Royal College of Psychiatrists is truly an international organization. And therefore, the structure of our international division, distributed geographically with 6 international divisions, to reflect the spread of its membership outside the UK and across the different continents. So that's from membership-wise and structure, but reflecting also the international really nature of our college. We have the MRC Psych exam in centers across the world, in Oman, Singapore, Malta, Hong Kong, and India. Our CPD online for psychiatrists is shared with the colleagues in Australia, New Zealand, the Netherlands, Estonia, and Malta. Faculties of the college are engaged in shaping policy in Europe and beyond. Our leaflets and public information translated into 25 languages. Our Center for Quality and Improvement has 27 members outside the UK. We have a very well-established and developing medical training initiative, which allows opportunity for colleagues from overseas to come for a limited period of time to have further training in the UK. And most relevant for today is we have a very active volunteer scheme, and probably one of the largest, if not the largest special interest group, and that's the Volunteer and International Psychiatry Special Interest Group, with activities across the Sub-Saharan Africa, India, Middle East, North Africa, and Myanmar. And this is reflecting the ethos of the college in supporting colleagues, especially in low and middle income countries. Therefore, it was really important to capture all this good work the college is engaged in and at a strategic level. And that's when last year, a concerted effort with wide-ranging consultation and series of workshops from all aspects of the college have worked together to deliver its first international strategy in June of this year, which, as you would expect, it has to reflect the values and the principles of the college. You will find, colleagues, we were hoping to share with you the strategy itself, but if I can just direct you to the chat where you will have link to the website of the document. But just really to emphasize, it's the principles of it. It's based on the values and the principles that governs the college international work. It has been strengthened by a strong operation model that makes sure that we are not engaged in any activity unless that we have all the reasons and the basis for success. One of the things that we'll talk about it is that we adopted a three-way collaboration where not just the college and the host or receiving kind of organization or country is the relationship extend to a third party, which is usually the ones that interested in supporting those services in whatever country, and also can help with the logistics. Because as a college, our strength, we are a human resource. We can share with the world our expertise, but we are not very. It shouldn't be our strength to provide logistics and of kind support, and that's why we play to our strength. It's important to develop other aspects of the international work in terms of exams, in terms of trainings that we aim to support, and that with that hopefully it will provide additional resources so we can support the volunteering agenda. The college demonstrated its commitment to implementing this strategy by appointing a presidential lead for international affairs, that's myself, to work together with the leadership team and the International Advisory Committee to implement this strategy. It also enhanced the resources for the international team and revamped the International Advisory Committee to reflect the strategy so we can be clear about the objectives and the implementation and the progress against those objectives. What I would like to share with you is that the exciting news that we started in a very difficult time, as you will be aware, in the middle of the crisis of the COVID, and clearly travel is almost impossible in the circumstances. But in spite of all that, and in very early days, but we have projects that we will continue to support, existing projects that colleagues have, for example, in Myanmar and other countries that already existing. But in addition to that, we are engaged in a number of new projects, this is really the exciting news, especially for colleagues who are interested in volunteering. There will be coming opportunities. We are in discussion with colleagues in countries like Ghana, Uganda, Palestine, and Belarus. These are countries that we've been approached to support, and work is underway to make sure that we have the right infrastructure, we have the right processes, and we have the right volunteers to deliver on these approaches from colleagues. I think we were all given 8 minutes. I think I'm about to finish my 8 minutes, but really I just wanted to share with you that the progress that we have made so far against the strategy, and again invite you all to go to the website, have a look at the strategy, and where you feel you can contribute, you are more than welcome to approach me, write to me, or to the international team and share with us your interest. And thank you again for the opportunity to talk about the international strategy.
Hello, everybody. Multiple apologies for the technical glitch. I'm Sophie Thomson. I was chairing this meeting until this happened. But because we have time constraint, we will now move straight on to the second presentation from Heather Dipple, who's been working in Ethiopia, and she's going to introduce her colleague, Dr. Sewbesew, who's prepared a video for us. Over to you, Heather.
Good afternoon, everyone. We got here eventually. So I'm briefly going to tell you about the Leicester-Gondar partnership. Gondar is a city in the north of Ethiopia, which is famous for its historic castles. Our partnership was started over 25 years ago and has involved several different medical disciplines as well as university departments. Psychiatry became involved in 2007 when the Dean of Gondar Medical School asked us to help with teaching psychiatry to the medical students. We were invited to go out at a time when there were only 2 mental health nurses in Gondar, serving the city and the surrounding population. Since then, over 30 mental health staff from Leicester have visited Gondar and contributed to both training and service development. Over time, we have seen the Ethiopian government develop mental health services, and there's now a thriving psychiatric department involving nurses, clinical psychologists and psychiatrists. For me, it's been a really rewarding and enriching experience being a volunteer. I've learned more about cultural sensitivity, about the importance of close collaboration and mutual ownership of any project, which needs to be sustainable. I've seen the need to be flexible and adaptable to changing circumstances, such as our current time. And it's been a real privilege and pleasure to develop relationships with people in Gondar, many of whom I now call friends. So I am very pleased to introduce to you Sewbesew, who I first met when he was a medical student. Since then, he's completed his postgraduate training in psychiatry in Addis Ababa and has returned to Gondar to be their first employed psychiatrist. He's going to tell you about the psychosocial impacts of the pandemic and also make some comments about our partnership. Over to you, Sewbesew.
Ethiopia, particularly at Gondar University Hospital. I will discuss a little bit about the psychosocial impact of COVID-19. It has been 6 months since the first case of COVID-19 in Ethiopia detected. Since then, the number of cases of COVID-19 increased, and currently we have around 68,000 individuals who have been infected with the virus, and we lost around 1,100 individuals due to COVID-19. So since the pandemic started in Ethiopia, there are different measures taken by the government, like declaring the state of emergency, restriction of social gathering, and including lockdown measures and restriction of transportation between cities and some other social activities. So these measures taken by the government create some kind of fear and anxiety because most of the people, they do have close physical and social contact. They are accustomed to live together physically and socially, and most people follow different religion, and we do have those close proximity to the spiritual places, which is being prohibited by the government as a state of emergency, so as to decrease the spread of the infection. Those measures taken by the government affect psychological aspects of the individual. There is fear and frustration among the population about acquiring the infection, and different social and physical activities being prohibited may create a psychological distress, and people are having psychological reaction. Based on that, we conducted a study, which actually I was a principal investigator, a community-based study, which comprised around 660 samples. So from those samples, we found out around 32% of them, they have depression, and around 26% of them, they have anxiety, and around 50% of the samples, they have a significant distress based on our findings. So when we look at factors associated with those psychological distress, female sex, unemployment, those having chronic medical illness, and those who use psychoactive substance like chat, cigarette, and alcohol, they are at risk of developing those psychological distress because of one thing, those having chronic medical illness, they discontinue their follow-up because of fear of acquiring the infection, and those who use psychoactive substance, especially tobacco, they fear about acquiring this infection because it's believed that COVID-19 affects the respiratory system, and smoking leads to those respiratory problems concomitantly. So most of individuals, they have severe psychological distress associated with the pandemic. Saying this, I'll discuss a little bit about the Leicester-Gondar collaboration, especially the mental health aspect, and how it could be affected by the pandemic. As we know, it has been a decade since the Leicester-Gondar collaboration established. Since then, the Leicester team helped us in the expansion of psychiatric service, both inpatient and outpatient psychiatric service, and they established a ward, a very comprehensive ward, and they expanded the outpatient department based on their collaboration. So this collaboration may be affected by the pandemic because there may not be frequent visits like by the Leicester team, especially Dr. Heather with her team. She had frequent visits which is affected by the pandemic. So this may discontinue the collaboration. And still there is expansion of outreach community service. They bought a car for that particular service, which now arrived in Ethiopia and ready to serve the community. So this kind of collaboration need to be continued even during the pandemic. Still, we need to have provision of personal protective equipment. One of the reason why health professionals are having psychological distress is because of lack of personal protective equipment. So we need to strengthen the collaboration to have those kind of equipments and facilities supported by the Leicester team. Still, we need to have online webinars, seminars on a regular basis, which may help us in a way of managing severe psychological distress associated with COVID-19. So the consultation and some other discussion could be continued through webinars and some other discussions. So this should be strengthened. In addition to that, we need to have strengthen the Leicester-Gondar collaboration after the post-pandemic era. So still we need to have exchange of staffs and like training, short-term and long-term training could be provided, which may strengthen the capacity of the staffs working at Gondar University Hospital. So these are some of the points. Thank you for watching me.
Right, thank you very, very much for that wonderful explanation. It's great to have a first-hand account about how COVID has affected mental health in Ethiopia. And it's good that a UK partnership has been able to be helpful both in the past and now. So thanks very much again. Right, it's now time to hear from Anis Ahmed, forensic psychiatrist in Birmingham, who's been doing some excellent work in Cox's Bazar, Bangladesh, where he's offering some direct supervision to frontline workers. Over to you, Anis.
Okay, thank you, Sophie. I hope everyone can hear me loud and clear. We did have a technical glitch, but I think we should be able to. Oh, my slide sharing is disabled. It says host disabled participant screen sharing. I'm just waiting for.
You should be able to do it now.
Okay, okay, I've got it now. So here is my slide share. Okay. Well done. Okay. So I think in the interest of time, I'll probably whiz through some of the slides. I think the first probably experience I can share with you, this is not uncommon, having this kind of technical glitch. And I think over the year, what I learned being a volunteer to be adaptable to all circumstances and it become a strength for you to move on. So that's me. I was in the camp. This picture is taken the year before last in the Rohingya refugee camp. The plan of my presentation is just to do a personal reflection. What drove me to this volunteering, what I learned, and what one can do to promote volunteering, and shed some new light what COVID brought in this crisis with the Rohingya refugees. So going back to my story, in 1988, I was in high school, and I just read a news that a doctor, Shahriyar, he died in a boat accident while returning from humanitarian work serving the flood affected area. And that's just the news. And actually I was happy at that time because of the great flood. All the schools are closed. It didn't affect in the household area that I was living. It didn't bother me. It was just news to me. Later on, when I was in the medical school, I came to know one gentleman who told me Dr. Shahriyar didn't die actually from the boat accident. What happened, because he was a very inspirational character, people follow him for humanitarian act, and there has been a number of youth who went with him to serve the flood affected area, but some of them didn't know how to swim. So on return, one of them fell off and he actually jumped into to save a few of them, and eventually he was exhausted and he drowned. And the person who told me that that story, he was the brother of one of the victim, and he held my hand. He says that I heard that you went to the medical school where Dr. Shahriyar graduated from. I wish one day you could be a doctor like him. I must be candid. At that time, I thought that, okay, being volunteer means you lose your life. You'd stay away from volunteering. Now then, in 99, so 10 years later, I'm a bit matured. Again, there was a strike in Dhaka Medical College. We in turn called a strike because one of our doctor was assaulted by some family members. At the mid, I think on that day, I don't have the picture of Dr. Asad, but he must be living and working somewhere because he's only a few years senior to me. I met him for a few hours on that night. He was the only A&E registrar who handled all the cases attended. And most of them he diverted to nearby hospitals saying that we are closed because of the strike. So in the midnight, there is a patient, middle-aged patient, he came with a urinary retentions. So as usual, this patient was referred to elsewhere, but very early on the morning, this patient came back because there's a long queue, all the patients there, and he was screaming in pain. So on that day, I saw Dr. Asad's leadership and his compassion. He gone against all the strike. He asked me to come and assist him to do a suprapubic stab because this is the only things that we available with the saline set. And we relieve all the retentions and save that person's life. So coming back, so these are the two doctors who become a role model for me. And even after 30 odd years later, I remember them. One of them I've never met. The other one I met only for a few hours, but they remain my hero. Now my project with the Rohingya refugees, I thought that if I give a background, people will understand. This is a map created by a group in the USA called Prevention of Genocide. And apparently in 2015, they predicted the areas where possible mass atrocities could happen. The darker areas are the high risk. So this is where the Myanmar and in Bangladesh border. So this is where the Rakhine state is where all the Rohingyas have been living, and they have now expelled from their own country. And this is a drone's eye view of the camp itself. Now, it may look very romantic, but those of us who have been there, it's a place of hell because almost 1.5 million people living there in a very basic conditions. They're not allowed to make any permanent accommodations. They're only allowed to make makeshift accommodation because the idea is that they should go back to their country of origin. And another thing you will notice that the number of children, I think 60% of them are youth and children. There is no activity available for them. They're not allowed to go out of the camp area. And they are fed with only very basic food and nutrition. So there are, as a result of this, of the atrocities they have faced, there are lots of cases of depression, anxiety, as well as a few cases of psychosis. Now, that led to me, when I came across of this situation there, and I thought that as a volunteer, what I can do. I started joining the VIPSIG at the Royal College of Psychiatrists. I learned about MHGAP and psychosocial first aid. And then I went to the Cox's Bazar to train some of the NGO staff. Subsequently, because when I'm back here, I provide some supervision through the Zoom. And this is, I think, probably one of the best thing happened following the COVID. Many places, they have invested on the internet as well as the computer facilities so that people can work remotely. And I've run some webinars routinely for local staff once in a month. Now, what I learned, first, do no harm while you are up for volunteering. The reason I said that without appropriate training and orientation of the locality, you may do inadvertently things that might not help them. And later on, I'll come to talk in detail some examples. One need to have a cultural competency and culturally sensitive intervention that is available. The other thing you need to be aware of, there is a lot of literature nowadays about volunteerism, and there are critics that by volunteerism you probably do some harm and also foster malpractices. Now, the other thing that I learned, that we need to revisit the Hippocratic Oath, because I mentioned the Hippocratic Oath earlier, that first do no harm. But also, you need to look after yourself. You need to have an oath to self-care and well-being, because most of us who do the volunteering are doing our job, day-to-day job, and we have our family members. So you really need to have a time for yourself as well as your family when you commit yourself any other activity. It can bring emotional labor on you, because you may come across with horrendous stories and see the cases which are very traumatic. And sometimes you get into the mission drift. For example, when I was providing supervisions, they would bring some cases and they would ask me to prescribe something or to bring them a solution to the clinical problem, which I can't do it from that distance. The interventions that I find helpful are culturally sensitive psychosocial intervention, modified CBT. I'm going to explain a little bit on that, and resilience building activity. What do I get in return? Knowledge and wisdom that I gain, and I'm feeling valued and useful. And also, I think the leadership skills that I got. I met a wonderful group of people which otherwise I would have never come across. I provide 2 links where you get more evidence what the volunteering benefit brings to you and your organizations. I think in this slide, this is a live dashboard. I've just screenshot it from the Rohingya refugee camp area. You'll see 500,000 cases are dealing with musculoskeletal problem. And again, 2.5 million consultation with the malnutrition. This is an example of modified CBT. You have fingers. So the 5 fingers represent 2 persons and 3 organizations. Then you can go health. The palm crease for 2 helpful activities, and the wrist crease for 2 helpful sayings. So the embodiment helps refugees to understand this modified CBT. And I think the non-verbal intervention is much more acceptable to them because of language barrier as well as less awareness of mental health issues. I think, and I would like to revisit the logotherapy, which is Viktor Frankl's, who is also a survivor of the Holocaust. Now, this is a quote from Karl Jasper, that which has happened a warning, to forget it is guilt. It must be continually remembered. It was possible for this to happen, and it remains possible for it to happen again at any time, any minute. Only in knowledge can it be prevented. But I think knowledge itself not enough, because this report was commissioned in 2010 or 11. They predicted genocide is likely to occur. Knowledge is not enough. Only through proactive action and accountability can it be prevented. This is my last slide. This is a picture, a photograph show. I take a picture with my iPhone. This young girl crossed the river to escape to the Bangladesh side. What strikes me, her defiance face, and she didn't forget to help her younger siblings to cross the river. I think this is what the volunteerism. And I would quote, we will not close our heart, will not look away other way, helping these unfortunate people. Thank you very much for your attention.
thank you very much, Anis, for a very moving account of both how you came to be a volunteer and the excellent work you're doing with colleagues in Cox's Bazar. I'm sure there'll be lots of questions, and I can already see a request for your slides. So thank you very much for that wonderful presentation. We now come to Peter Hughes. First of all, a huge thank you, Peter, for stepping into the breach and chairing the meeting. As ever, resourceful. Many of you may know that Peter has done an awful lot of global mental health work, and he's going to talk to us now about his experiences, including WHO perspectives. Thanks very much, Peter. Over to you.
Okay, thank you. And can I share my slides now? Yes. Yes, okay. But before I share my slides, some of us have just come from the WHO World Mental Health Forum. And that's like the Christmas of mental health, WHO. So I thought it might be helpful just to pick up a few points that I picked up from there to share those. And if I sacrifice a few of my PowerPoint slides, they'll be shared. You can all see them at the end. So this is a very important meeting every year where we talk about mental health, and it's transformed to talk about COVID. And thinking of Anis's talk last talk, even because I worked in the same place last year, and it's totally converted into talking about COVID now. All their focus is on COVID. But on today, from just discussion today, we had a whole session, and I didn't actually hear the word PTSD mentioned once. We talked a lot about alcohol and substance abuse. And what really was striking was how alcohol and substance abuse seems to be so much linked with COVID, which in turn is linked with death and morbidity and mental health. Groups that are very vulnerable are the elderly, children, refugees. Some talk about being prepared, but I don't think anyone could be prepared for something like this. And these things expose weak health systems. So this is where we get into real difficulties, because so many of the countries that we volunteer in have very weak health systems to start off with. And to do volunteering, you need to have a good background of public health and public mental health. But I can tell you that from a WHO perspective, they are totally focused on COVID at the moment, and they're very much integrated with all the other emergency pillars of COVID response. So they did a rapid assessment in just about every country and realized that what the result of that was that services, mental health services, are severely affected in just about every country. 7% of services only are open without disruption. And the scope, the range of COVID is just so extensive. I was in a country in January, and I think that's about one of the few countries that are still aren't reporting any COVID cases. But otherwise, it's almost all countries. What struck me as well was discussion about seriousness of effect on neurological disorders. That there's about 35% of people with COVID may have neurological disorders associated. There was a discussion about mental health being cross-cutting. And this is even more than any other disaster I've been to, that COVID is covering nutrition, education, just about every livelihood, every field you can think of, COVID is affecting. And mental health similarly then becomes cross-cutting throughout those areas. With COVID, there is stigma. But even with all that, when they've looked at the finances, for example, only 17% of countries have provided extra funding for mental health. What WHO and their partners, a lot of what they've done is provide excellent protocols and guidance. and they are referenced at the end of my presentation in the slides that you could look at. There's just about everything you can think of, guidance for children, guidance for adults, guidance for antenatal care, etc. Another thing that I thought was quite nice is they've collected case studies from about 40 countries of learning from COVID and how you work that. Today's talk, there was a lot about working online, etc., as you can imagine, and how they've changed and adapted. Another thing that I think was very important is that in any development of services or response to COVID, you must have participation from the local community, including people with lived experience. Anytime you're doing something about mental health, you must need people with lived experience. So now I'm just going back to my slides now, and I will rush through those a little bit for time, but as I said, you can always see them. And in fact, they're not moving. Oh, so sorry about, oh yes. So just going back to my side, from my own personal perspective, I've been involved as a volunteer for many, many years, and COVID arrived and immediately I had to stop trips I was planning. But what I did was I changed them from like a training on MHGAP in the Middle East, I became online. Supervision went online, doing lots of webinars. Staff support was online. And it really has been, hasn't been as bad as I expected, really, in terms of delivery and being involved with global work. So dealing with a pandemic like this, the natural group you would approach is WHO. And this is in their mandate, along with, and they are working along with many different organizations, Red Cross, International Medical Corps, many organizations producing many guidelines and guiding countries around the world on how to respond. One message that they are saying is, whereas other disasters are one point in time, or COVID is like a chronic disaster. So our models of things like psychological first aid need to be adapted, and there are adapted materials for this chronic disaster. Now, what we expect from the books in terms of what happens with disasters is exactly what we've seen. Increased rate of depression, anxiety, violence, substance abuse, stretched health systems. I'm going to, now there's some really good documents, but I'm just going to summarize it as, in organizing your health service, you kind of turn up the knob for moving your health people around, your human resources, and you turn it down when the crisis is over. I think that's kind of a summary of some quite in-depth discussions. Direct and indirect mortality. People are definitely not approaching health services for their mental health, let alone their physical health. So things that are needed are coordination, having protocols. Human rights are really important to keep going right throughout. Public health messaging is one of the most important things. Depression, anxiety, neurological disorders, substance use is a huge issue, and gambling is another thing that came up from the meeting today. That's really become an issue. I've got to finish now in just a moment, so I'm just going to go further. Yeah, some useful tips about like online working. Try and see your patient first face-to-face. Follow up online. Psychological therapies you can do online. This document is there for you to read and have a look at. I don't have time to go through that, I'm afraid. This is a nice document, an orientation to basic psychosocial skills. And this is what I really would recommend, looking at how you provide basic psychosocial skills, looking at what is helpful to people in distress. includes things like how you manage funerals, self-care, as you can imagine. I know my time is almost over, but problem solving, positive coping methods, and some of the things like Anis mentioned about the hand. So as a volunteer during COVID time, you'll be doing a lot of stuff about anxiety management and depression, same as our sleep disorders. And there's, yes, just to mention again, there's specific guidance on neurological and mental manifestations with COVID-19. There's such a lot of neurological abnormalities that's really alarming. I am going to leave it at that. Oh yes, I mentioned that My Hero Is You storybook for children. Just a really nice thing for children to have a look at. With that, I finish, and hopefully you'll have share the resources, share the slides, and can access these resources. Thank you.
Just on mute a moment, Sophie. Sorry, what I said was thank you very much, Peter, for a hop through a very big and important subject. And thank you for highlighting the important issues. I'm sure there'll be lots of questions, and I do hope people do follow up this material at their leisure, because it's spot on with global mental health and the COVID crisis. Unfortunately, we don't have a week to really go into this, because we now need to have our final speaker, which is Rohigya Page, who's very interested in the development of electronic digital learning, and he's going to talk to us about the future of technology in international volunteering. Over to you, Rory.
Thank you very much, Sophie. I shall just get the slides up and running. Thank you. The future is exciting for international volunteering. We're fortunate to live in a digital age where technical innovation is progressing faster than ever before. The use of internet-based technology in healthcare and medical education has been forced to evolve at a rate never seen before as a result of the COVID-19 pandemic. Its effect on workforce delivery, with the ever-increasing barriers to face-to-face working, both within the healthcare and non-healthcare industry. You may wonder why a picture of the ancient Nokia 3310 phone and iPhone are on display on my slides. Just like the progression in recent years with electronic smartphone capability, the field of international volunteering has also been forced to evolve with the ever-progressing world of digital software and mobile data connection. Internet-based tools have long been successful in sustaining international volunteering projects long before COVID-19 embraced us all. The WHO's MHGAP has been available via electronic format for many years, enabling easy access by health workers across the globe. The use of video in international teaching and volunteering has been pioneered by MHGAP with a wide range of teaching videos. A personal favourite of mine is that on the top right of the screen, the MHGAP psychosis video. But this is one of many videos which have been successfully developed as a key training tool in international MHGAP and other psychiatric training. The MHGAP manuals and videos are updated regularly with new versions, used in more than 90 countries and have been translated in more than 20 languages. Internet-based teaching software has previously been the main player in the world of electronic international volunteering. One example which I have very fond memories of is the very practical and low bandwidth Medicine Africa website, which has facilitated remote cross-cultural education in a problem-based learning format for many years, long before the current advances in software. This peer-to-peer global mental health e-learning project called Akun via the Medicine Africa website was revolutionary with regards to the development of international volunteering online, and allowed keen volunteers like myself to follow up with the same training cohorts, such as this medical student group I was involved with training in Somaliland back in 2015. I was amazed. The transition between the face-to-face teaching in Somaliland and online learning was seamless. I found myself training the group in Somaliland on Friday, having to say our goodbyes before landing in the UK, picking up the laptop, and I was back training online with the same group who I'd only seen a couple of days before in Somaliland. The main joy for me was being able to follow up with the same group and watch them nurture their psychiatric history examination and diagnostic skills that we had practiced in person, or from the comfort of my own home. It was fantastic. The dawn of COVID and the resulting social distancing and isolation requirements for health workers have resulted in the UK mental health trusts developing video conferencing strategies to enable effective communication, such as Microsoft Teams and Zoom. In the UK, we found that the use of video conferencing has evolved rapidly, with use both in clinical and educational settings. Gone are the days where video conferencing equipment was extortionate in terms of cost and inaccessible by all. Nowadays, in particular, due to the increase in demand from COVID and the need for video conferencing software to be available to everybody, subscription to the necessary software is cheap and readily available. Video software such as Microsoft Teams and Zoom are available in app form, so you can even connect with colleagues far afield and in different countries, even from your work car park or garden should you desire to. The use of technology in remote locations has been well evidenced for many years, long before the COVID-19 pandemic, and has been extended to include carer education and supervision of staff. You may think that I'm digressing a bit from the talk, but we as international volunteers have a lot to learn from our NHS colleagues in response to the recent speed and forced hand nature of video technology development as a result of the COVID pandemic. What we found in the UK is that video technology is being increasingly used with great outcomes, including witnessing major benefits to improving educational programs, promoting attendance and involvement, while also adding a major cost benefit in reducing travel time and cost for clinicians. In my opinion, the future for international volunteering is clear. We need to learn from COVID. We need to learn from colleagues in the NHS and the developed business world with regards to how companies, including healthcare trusts, are developing online-based practice. Many low and middle income countries, in particular those with established universities, medical schools and teaching hospital sites, are now equipped with sufficient internet and mobile data connection to allow for the same remote learning that we are facilitating in developed countries like the UK. Of course, the same limitations will apply, such as sufficient bandwidth internet or mobile connection, time delays, language and cross-cultural issues. But as long as these can be worked around, what is stopping us from inviting colleagues from different continents to the same teaching sessions which we're already delivering to UK-based colleagues? Or by recording volunteering training sessions, such as the very well-received MHGAP orientation training weekend, for access for those available at a later date, regardless of where they're located on the planet. The future of international volunteering would be to one day establish a multi-video conferencing network to deliver a worldwide mental health volunteering program and the development of an international community of practice across our volunteering projects, with the aim of targeting professionals specifically considering volunteering and setting up new remote projects. Moving forward for the international volunteering community, the use of video conferencing spanning across multiple projects and sites would support a worldwide volunteering community of practice and encourage networking between the volunteering projects across the globe. An international community of practice could, in future, even provide extended multidisciplinary peer reviews of complex and challenging cases and ethical dilemmas. The process of remote partnership working across the international domain could allow for joint problem solving, creative thinking across services. It would avoid project isolation and ensure a consistency of approach to the delivery of volunteering and mental health across the planet. I must emphasize that despite the very clear benefits and progressions with the potential of a virtual international community, this should not take away the importance and benefits of continued face-to-face training. Any international virtual community could only be strengthened with, and not a replacement to, continued face-to-face training, what we like to call field work, with the use of technology there to only offer additional assistance to and provide additional volunteering opportunities. We must not move away from face-to-face projects and instead promote remote volunteering as a domain for promoting the sustainability of projects and for those keen volunteer colleagues who are unable to travel long distances or commit to lengthy periods away from home. In summary, video conferencing technology is now well developed, well received worldwide, and has rapidly evolved due to the COVID-19 pandemic. Our international volunteering technology approach to date has been based around chat-based programs and supervision programs for existing projects, such as my much loved example of Medicine Africa. Whilst these have worked extremely well, there are significant compromises in terms of the lack of audio and video communication with the current international training software available. The ideal solution would be to have the same, more evolved, dedicated software program used amongst the global international volunteering domain with easy access for participants, regardless of their organisation, project or location. The future is exciting for international volunteering. A blend of traditional and new is required. Watch this space.
Wow, Rory, that was quite a journey back from Nokia to the thoughts about the future. Thank you very much for that exciting summary of where we're probably going as digital learning and communication with our colleagues overseas also helps the planet a bit too. We don't have to fly anywhere, so we look forward to seeing what happens next. So that's the end. Thank you, Rory. That's the end of our presentations. Thank you very much for your patience, for the resourcefulness of the presenters to work around our technical problem. They won't happen so much in the future, will they, Rory?
Trust.
But now I think we're going to ask if we can, we've got now a quarter of an hour for questions. But we can go on a little bit after 5:15 if there's sufficient interest. So I see there are already some questions, but if not, get typing. And Jane, I'm going to hand over to you in a moment to see if you've been able to gather the questions together and field them to our speakers. Over to you, Jane. Thanks very much.
Well, yes, we have thanks from me to all the speakers for this fascinating presentations this afternoon. There's a few questions coming through. The first of which I would like to direct Peter Hughes. It's from Shahriyar Ramakrishnan. Does VIPSIG have any existing guidelines on cultural competence for psychiatrists volunteering in low and middle income country
cultural competencies?
Yes.
Okay, I would just direct people to some of the anthropology and papers and the cultural primers. For example, there's one about the Rohingya in Bangladesh. There's a cultural primer on Syria, a few Somalia. So we don't have cultural competencies as such in any sort of formal sort of system, but we would really advise for anyone going to volunteering that you brush up very much on the cultural background, and that you always are aware of that you'll never be from that culture, so you'll never probably understand it completely. So you have to be with that respectful, humble attitude, I guess. Thank you.
Thank you. Okay, another question from the same participant to Anis this time. This is from Jairam Ramakrishnan again. What is the magnitude of yaba or methamphetamine use problems in Cox's Bazar? particularly with a view to age and gender pattern of use?
Okay, it is a big problem. And as I mentioned earlier, in case of disaster-prone area, there is no law and order. And unfortunately, illegal drug trading is a lucrative business. So that is a belt area where drugs are traded, and usually the young people get involved either as a middleman to transport the drugs, and sometimes they end up using it. I don't have the statistics, but I know that in the Cox's Bazar area, there has been routine violence over drugs, extrajudicial killing over drugs, and lots of political problem arising out of there. So unfortunately, I don't have an answer, but I know that there's a problem there. It's not only here. What I heard, everywhere where there are a disaster-prone area, no law and order, this is a common phenomenon. Peter may be able to answer more.
Yeah, and I can't find the hand up function here. Maybe that's just Teams. And it's just, yes, because I did a bit of work with Yaba in Bangladesh with the Rohingya, and it was really kind of like shocking because the Yaba is manufactured in Myanmar mainly, and the Rohingya camps are the sort of port of call, it's a conduit. And some of them are look like little sweets. So that was one of the problems where children were having them. But we sort of formulated, and actually a lot of the issue was about not so much the Rohingya, was the population of Bangladesh around the camps. But we saw that Yaba and the substance abuse problems were a kind of a relation to problems and stress in people's lives, and we saw it as a stress response. I have been to some of there's a rehabilitation place in Cox's Bazar, and they have some programs there, but there's actually a real big gap in rehabilitation and drugs counseling in the Rohingya camps. I don't think it will be much better than last year when I was there last.
Thank you, Peter. There is a comment from Dr. Mohammed Inam from the Sylhet Osmani Medical College of Bangladesh, stating that the mental health of Cox's Bazar Rohingya refugees is a burning issue. Thanks to the Bangladeshi government for helping them, but the International Psychiatric Forum should extend their hand, including Royal College of Psychiatrists, to improve their mental health. Moving on to further questions, I see there's one from Oliver Sargent, and this is addressed to all panelists. So perhaps we could go with Professor Al-Uzri as a start, to just go in order of how you spoke. Will more volunteering work remain online post-COVID, or is it too limited to replace in-person interventions?
I think, as some of my colleagues already mentioned, that it's one of the good things that come of these adversities is that the push for the use of technology, and in that case the online. I think it would be difficult not to use it in the future. I think, as mentioned, face-to-face remains the kind of best case scenario. But I think we have learned from international work that it need to be supplemented with supervision, with follow-up. And the logistic and practicalities of delivering follow-up and supervision always on face-to-face is really unrealistic. So I think there will always be a strong place for online volunteering, and I think it will supplement any face-to-face when it comes back. Thank you.
Thank you, Professor. Does anyone else who would like to go next?
Sorry, Peter. Oh, I don't know whether I could add a point there, Jane, if that's okay. I certainly think there's a major role for internet-based and online volunteering. But as I alluded to in my talk, for me, it's not a replacement for face-to-face. I think the key word to identify where we are going with online volunteering is sustainability. And with online training, similar to the successes from Medicine Africa, it's about keeping the project sustainable. Without ongoing and continual work for the projects outside of the face-to-face contact, any project will be deemed to have difficulties. And online training, similar to online supervision, similar to everything that we're doing outside of those face-to-face contacts, it's the importance of sustainability is key here. And that's where use of online resources, use of online webinars, access to webinars like today's first go of this, of which we've done, is key for this. So I don't think it should replace face-to-face teaching ever, and only ever be used for sustainability of programs.
I'd just like to say, I think to understand the culture, it's very important to go somewhere. I think however much you explain it to people who are about to visit a place, which we've done numerous times to people visiting Ethiopia, they don't quite get it until they get there and understand and talk to people and live in the way that people are living there. So I think the face-to-face thing is critical for that. But I think after that, absolutely, you can continue relationships online.
Thanks.
Can I just put a comment on that one as well, Jane?
Yes, please.
I think we need to look into the practicality because, as I said, volunteerism is not always an easy task, and these problems that we are seeing, volunteer is not a solution to this problem. It may be an add-on. Now, it may not be possible for everyone to travel, but they could always do a little bit of help through the online platforms. So there will always be a space for everybody to contribute in online, and I'm up for it.
Well, we have a question here from Sachin Shetty saying, what opportunities are there for online volunteering through the RCPsych? Mohammed.
I mean, I'm really pleased to hear that people are interested and would like to volunteer. As I alluded to, I think when we launched the strategy, we thought we're not going to be able to do any more volunteering. We're only going to sustain, basically just support and sustain the existing one. And we had conversation with Sophie, with Peter, and at the time. But to our pleasant surprise that opportunities came, and some of those projects are already underway and we are delivering. For example, the Palestine project, we already delivering sessions online in collaborations with the other organization. We have approaches from 2 countries in Africa, and we will be reaching out for you volunteers to help contributing to that, one in Ghana and one in Uganda. And we also been approached through the World Psychiatric Association to help with the situation in Belarus. And again, we will be approaching the volunteers to see the appropriate, linking the appropriate expertise with the request that comes from those countries. So the message is, yes, it's a different world. No traveling is taking place currently, but there are still opportunities for contributing through online until a better time when we can go back into face-to-face. Thank you.
Thank you, Professor. I have another question on child psychiatry. I don't know who to direct this to. I don't think we have a child psychiatrist on our panel. From Anne Shortall, I am a child psychiatrist. Where does the panel think child psychiatry sits in international volunteering? I'll give that to Peter and then Heather.
I can give you a very concrete example. We were requested, well, we kind of were, I did some training for Northwest Syria, and we organized some follow-up trainings. We found that they had a need for child psychiatry, we organized for a UK volunteer to do online teaching with Northwest Syria. Always there's a gap in child psychiatry. Child psychiatry is probably one of the big needs for many low and middle income countries.
Thank you, Peter. Heather?
We've had involvement of child specialist nurses and psychiatrists going out to Gonda, and they've contributed to medical student and nursing teaching, but also they've got alongside other organisations that are delivering services to children, especially children with disabilities, because they come across a lot of children with mental health problems as well as physical disabilities. So our child team have been able to work through the field workers in the villages, helping with basic management of psychiatric disorders. So I think there are ways, if you know the service you're going to, you need to find out who's doing the work and then find ways of helping with it.
Thank you very much. I have another question here from Andrew Kevern on the subject of library of teaching sessions. Could it not be a role for VIPSIG to create a library of teaching sessions in all specialties, which might be freely available for medical students up to consultant level? Obviously, he means in the topics needed for global volunteering. Professor Al-Uzri, would you?
One of the things that we talked about in the development of the international strategy is that to share the really rich resources that we have within the college for colleagues overseas, especially in low and middle income countries. So I think that's where the direction of the travel, and to develop in cases where there is lack of specific packages, we are having discussion to developing those resources within support with the faculties across the different faculties of the college. So the plan is to have those access to those resources and make them available for the volunteers.
Thank you, Professor. Sophie.
Yeah, I think this is a terribly exciting idea, and I really look forward to how we can develop something that's going to be useful to do the blended learning of some international, some digital learning and seminars face-to-face. I think this is a very exciting way forward. But while I have the panel, Jane, I have to remind you that we're now 17 minutes past 5, and people may be wondering, are there other more questions you think we need to attend to? Is there one more we could do, perhaps?
There's just from Manai, please mention women's mental health and perinatal mental health. I don't know who would like to take that question. Is any?
Why don't you, Jane?
I don't think I can say a lot on that topic. Obviously, it's a hugely important topic and a whole field of its own. As Heather said, we need to link with the specialists in the relative countries to support their work, and I see that Peter wants to say more.
Well, I just think for maternal mental health, I mean, there are some really interesting materials now called like Thinking Healthy, which is used in Pakistan, which is about supporting women through the antenatal and perinatal period. And it's a protective, it's like prevention rather than just dealing with mental illness treatment. I think the other way I see it in volunteering is that you give very strong messages about mental health in the antenatal and perinatal period for people who are learning about mental health, particularly in primary health care. Most low and middle income countries that I'm familiar with probably don't have the luxury of a mother and baby unit, but they all need expertise about dealing with conditions of perinatal psychiatry.
Thank you, Peter. Okay, I think
Yes.
we're. Oh,
Sorry, last comment.
Sorry, just wanted to add on the Peter's comment. I think I'm very glad that these highly specialized units such as camps and the parental psychiatrists, they can probably make the biggest difference into those populations. I can only talk from the Rohingya refugees camp there, because mainstream medical school doesn't teach people about those things. So most of the doctors, all the midwives, the nurses are not aware of at all. So what basically they need, and what I try to do during the staff training session, just to mention them some of the basics that I think they can pick up, the disorders, and then they can divert it to the appropriate service. I can give you one example. I have seen one, I heard, I think in the supervision, there's a one case they mentioned about possible young boy with epilepsy. So obviously in the camp area, they don't have understanding epilepsy. They think that is a possession. So what I suggested, record it with your mobile phone and send it to any of the child neurologists. They did that things and they found it epilepsy, and the patient didn't need to go there because they don't have the resources. So all the prescription and everything done on the phone or on the internet. And when in the subsequent supervision, what I heard that those epileptic seizures have been under control. So I guess this is where the expertise can do even from here, training the staff.
thank you.
Jane, do you think that we should pull this to a close now?
Yes, we managed to answer most of the questions, and if you send us your emails, we can endeavour to answer the few that we might have missed.
So shall we all say thank you very much for listening? I hope you found it informative and interesting and perhaps even inspiring, and helped you think about future volunteering possibilities. Thank you also for your patience, and a huge thank you to our panelists for fabulous contributions. I'm just sorry we don't have a couple of weeks to really expand on this in a full conference. So thank you, Jane. Anything else like to say anything, or shall we close for now?
I would really like people to give us their ideas about how we can generate more volunteering opportunities, because that will come out of people here in this forum. And we need people with interest and passion to make it happen.
Yeah, great idea. Yes, if you've got an idea about something you'd like to do, you think might work, we're very, very happy to talk it through with you and help make it happen.
And also things we need to do to improve on people's ability to volunteer through the college. We want your ideas.
Okay, I think that's a good note to say thank you all very, very much. We hope to meet you again. And thank you for your patience with our technical struggle. Okay, bye-bye.
Bye.